If a patient swallows a 20 milligram rivaroxaban pill with, just a cup of black coffee.
They might as well not have taken it at all.
Right. Welcome to the deep dive. Today we're looking at how the tiniest daily habits, like whether or not you eat breakfast, can completely shatter the efficacy of life-saving blood thinners.
Because, honestly, the stakes here truly cannot be overstated. Anticoagulation therapy operates on this really precarious pharmacological knife edge.
Yeah, it's a tightrope.
Exactly. The exact same biochemical mechanism that saves a patient from a fatal pulmonary embolism it's the exact same mechanism that can cause a catastrophic, life-threatening internal bleed.
Yeah.
It's just a delicate manipulation of human physiology.
And navigating that knife edge is exactly why we're here. To you, our listener, we've got a really targeted mission today. You sent us a phenomenal stack of sources to unpack.
A really great stack.
Yeah. We've got this highly distilled, rapid-fire sheet of the top 15 DOAC clinical pearls and a massive practice-changing study from the New England Journal of Medicine.
Published exactly a week ago, right?
Yep. March 12th, 2026. So our goal is to shortcut you to being exceptionally well-informed on DOAC therapy. We're going to separate the nuances of safety, lifestyle convenience, and, bizarre drug quirks without getting bogged down in all the medical jargon.
Which is deeply necessary in modern clinical practice,
Oh, completely.
In an era of intense information overload, understanding the nuances between these medications is literally the difference between a successful treatment and a dangerous adverse event.
Okay, let's unpack this. I want to jump straight into the biggest news in the sources to anchor our discussion.
The head-to-head.
Right, the direct face-off between the two most heavily prescribed DOACs on the market, apixaban and rivaroxaban. This is the centerpiece of the newly published COBRRA trial, which to me is like choosing between a highly reliable but, demanding twice-a-day habit
Apixaban.
versus a highly convenient but slightly riskier once-a-day shortcut with rivaroxaban.
That's a great way to put it. And the COBRRA trial really is a monumental piece of literature.
Yeah.
Up until this data dropped, our understanding of how those two drugs compared was largely based on, indirect comparisons or retrospective data.
Just observing after the fact.
Exactly.
Right.
But the COBRRA trial gives us the very first direct head-to-head randomized controlled trial specifically for treating acute venous thromboembolism, or VTE.
Okay, so what did they actually do?
Well, they took 2,700 adults, age of around 58, and randomized them. The regimens were totally different.
Right, I saw that. The apixaban group started with 10 milligrams twice daily for 7 days, and then stepped down to 5 milligrams twice daily.
Yep, and then the rivaroxaban group had a much longer initial ramp-up. They did 15 milligrams twice daily for 21 days.
Oh, 3 whole weeks.
Before finally dropping to 20 milligrams just once a day.
So rivaroxaban gets you that once-a-day convenience eventually, but what were the results?
The big reveal is in the bleeding events at the 3-month mark. Clinically relevant bleeding was 7.1% for rivaroxaban.
And for apixaban?
Just 3.3%.
Wait, less than half?
Less than half. A relative risk of 0.46.
That is a massive difference.
It is. But what's fascinating here is that despite the roughly 2 times higher bleeding risk with rivaroxaban, there was no difference in VTE recurrence.
Huh. So apixaban stopped the blood clots just as well, but with half the bleeding?
Exactly.
7.1 versus 3.3% is a knockout punch to me. Does this just close the book on rivaroxaban forever?
I wouldn't go that far. We have to temper the excitement a bit because the trial does have limitations. They only collected data for 3 months. And they excluded patients over 120 kilograms or anyone with cancer-associated thrombosis. Plus, limited racial diversity, only about 10% non-white.
Right, so we can't universally apply it to everyone just yet?
No. But the bottom line from the COBRRA trial is that rivaroxaban definitely wins on convenience, but the apixaban wins on safety, especially with GI bleeding.
Okay, but that convenience with rivaroxaban comes with a massive, and honestly often missed, caveat about how it actually gets into the body.
Yes, the food requirement.
Right. If a patient is taking 15 milligrams or more of rivaroxaban, they have to take it with food to increase bioavailability.
It's totally non-negotiable. If you miss this, you underdose the patient. The drug is highly lipophilic. It needs the delayed stomach emptying and the bile acids from a meal to actually absorb properly.
So if they just take it with coffee on an empty stomach?
It just passes right through. They aren't getting the full dose, which means they aren't fully protected from a clot.
That's terrifying. But here's where it gets really interesting. You look at the other DOACs on your list, like dabigatran. I'm comparing dabigatran to like a delicate gremlin from the movie.
A gremlin.
Yeah. It's intensely moisture sensitive. You literally cannot put it in a weekly pill organizer or it degrades.
That's actually a huge clinical hurdle. It has to stay in its original blister pack or the special desiccant bottle right until you take it.
Which ruins the Sunday through Saturday pill box routine for elderly patients.
Really does. And dabigatran is also a prodrug.
Meaning what, exactly?
Meaning it's inactive when you swallow it. It requires activation by enzymes in your blood and liver to actually work. That leads to a lot more pharmacokinetic variability between different patients.
So it's a bit unpredictable.
Exactly. Which brings us to metabolism, and specifically edoxaban. Edoxaban has a real superpower here.
Oh, right, the CYP enzyme.
Yes, the cytochrome P450 system, the CYP metabolism. Edoxaban has minimal CYP metabolism, less than 4%.
So why does that matter to you, the listener? I mean, why do we care about CYP enzymes?
Because the CYP pathway is notorious for drug interactions. If a patient is on complex medications like antifungals that inhibit CYP enzymes, drugs like apixaban or rivaroxaban can get backed up in the system.
Like a chemical traffic jam.
Exactly. The blood thinner pools in the system and bleeding risk skyrockets. But because edoxaban basically ignores the CYP enzymes, you get a much lower risk of those interactions.
Wow. Okay, so the liver handles some of the DOACs through those CYP enzymes, but the kidneys are really the ultimate deciding factor, right?
And without a doubt. Renal clearance dictates which drug a patient gets.
Let's run through the extremes on that. From your sources, dabigatran has the highest renal clearance, like around 80%, so you avoid that if the kidneys are failing.
Right, it would just build up to toxic levels.
But apixaban has the lowest, only about 27%, so that's the preferred choice for chronic kidney disease.
It's very forgiving for poor kidneys.
But then edoxaban is the weird one. It actually loses efficacy if the kidneys work too well. Like, if creatinine clearance is over 95, it increases stroke risk compared to warfarin.
Yeah, it's a fascinating paradox. If the kidneys are hyperfunctioning, they essentially wash the edoxaban out of the blood so fast that it can't maintain a therapeutic level. So you absolutely must avoid it in atrial fibrillation if they have hyperfunctioning kidneys.
That is wild. Okay, but speaking of kidneys, there is a massive trap in the sources regarding apixaban dosing, the 2 of 3 rule.
This is a major clinical warning. The FDA has this 2 of 3 rule for apixaban, where you reduce the dose if the patient meets 2 of 3 criteria: age 80 or older, weight 60 kilos or less, and serum creatinine of 1.5 or higher.
But the trap?
That it only applies to atrial fibrillation. It absolutely does not apply to VTE treatment.
Oh, wow. So if a doctor sees an 80-year-old with a massive blood clot in their leg and they cut the apixaban dose in half because of that rule?
They are severely undertreating a potentially fatal clot. VTE requires the full, unadjusted dose.
That's a huge pearl. And what about dialysis?
For VTE, there is zero solid evidence for treating VTE with DOACs in dialysis patients.
None at all.
None. Apixaban has some evidence for AF in dialysis, but for VTE, it's just a huge gray area.
Okay, let's talk about the practical reality of day one. A patient gets a clot. How do we start them on these drugs?
There's a big split here. Apixaban and rivaroxaban can be started immediately. You just swallow the pill.
Nice and easy.
But dabigatran and edoxaban require a parenteral lead-in first.
So like a heparin injection?
Yes. For at least 5 days before you can even start the oral DOAC.
I mean, asking a patient to do stomach injections for 5 days at home is a massive barrier compared to just taking an apixaban pill.
It's a huge difference in patient experience.
Okay, but let's look at the elephant in the room. We've talked about starting DOACs, picking them for convenience or kidney function, but what happens when the very thing we are trying to prevent?
The bleeding.
Right. What happens when a severe bleed actually occurs? How do we stop the train?
We use reversal agents, and they are very specific. Dabigatran has a dedicated antidote called idarucizumab.
Idarucizumab.
Yep, it's an antibody that binds directly to the dabigatran and neutralizes it instantly.
And what about apixaban and rivaroxaban?
They rely on prothrombin complex concentrate, PCC. It basically floods the body with clotting factors to overwhelm the drug's effect.
Got it. But I saw a dramatic update in your sources about another reversal agent, andexanet alpha.
Oh, yes. The FDA just recently pulled it from the market.
Why? I thought that was the big new antidote.
The FDA determined the risks outweighed the benefits. It had a significantly higher rate of thromboembolic events, essentially causing new, dangerous blood clots while trying to stop the bleeding.
Wow, so it was pushing patients too far the other way?
Exactly. And compounded by how incredibly expensive it was, the FDA just pulled the plug.
So what does this all mean? When we look at all these clinical pearls, the ultimate takeaway from your sources seems to be that apixaban is the safest DOAC overall.
The evidence strongly points there, yes.
Yeah.
The COBRRA trial proves it for VTE. It beats warfarin in the older Aristotle trial for AF, and it's the safest on the kidneys.
But we still have that dosing trade-off. Choosing between the once-a-day convenience of rivaroxaban and the proven safety of twice-a-day apixaban, it's a real daily decision.
And that actually leaves us with a final lingering thought to ponder.
Oh, I like these. Lay it on us.
So the COBRRA trial only tracked patients for 3 months, right?
Right.
How might that convenience versus safety paradigm completely shift if we had 5-year real-world data?
Wait, what do you mean?
Well, could the safer twice-a-day drug, apixaban, actually lead to worse long-term outcomes if patients develop pill fatigue?
Oh, like they just get tired of taking it twice a day and start skipping the evening dose.
Exactly. Over 5 years, human behavior gets messy. Could the adherence of the once-a-day rivaroxaban option actually make it the better drug in the long run, despite what the 3-month safety data says?
That is wild. The safer drug becoming more dangerous just because we are human and forget to take our pills. That is an incredible thought to ponder.
It really changes how you look at the data.
It totally does. To you, our listener, thank you so much for sharing such an incredibly high-yield stack of sources. Your curiosity is what drives us. You've given us a phenomenal roadmap for DOAC therapy today. Keep asking those hard questions, keep digging into the nuances, and we'll catch you on the next deep dive.